I've just got it. The recording. Okay, fine. Okay, well, good afternoon, everybody. We are going to introduce Professor Tufail Patankar. He's going to give us a talk on contour and its utilization in the treatment of aneurysms. Professor Patankar is an expert in utilizing the device, and he will now give his talk. So thank you very much, Tufail, for giving this evening.
It's a pleasure. Thank you. Nice to see you guys. Jonathan and Tim is on, is it? Okay, so let me share my screen. Let me know whether it works, okay? Start broadcast. Okay. Can you see my screen now?
Working perfectly.
Yeah.
Yes.
Can you see my screen? Yeah, perfect. Okay, thank you. So I think you asked me to first go through some intrasaccular device kind of thing. So I'm kind of going to give you guys some flavor about how it works. And I think the most important thing about intrasaccular technology is understanding where it stands today with all the other things that we have. I think that's where it goes wrong when people start putting webs and contours in every possible place. I'm going to start with ISAT. This is where, obviously change and revolutionize all our lives. Obviously, most of the practice is based on what happened many years back, and what Andy Mullen and his team achieved is been amazing. But that study continued, and I'm sure Andy must have shown you this talk, and this is a slide from his presentation, that it's very important that the benefits of coiling aneurysms has continued to stay over 18-year follow-up, and you can see that there is a significant reduction in the mortality, morbidity, and also in terms of the rebleed. As you can see, there is a very small amount of rebleed, and this is a very important paper. Although many of you guys will see on your surgeons probably never reference it because they don't want to, particularly in UK, where they are more and more, there's a lot of change in the attitude in terms of the neurosurgeons because they don't do endovascular, so they're trying to clip aneurysms. But this paper clearly shows that there is a significant reduction in the rebleed, and it's not significantly more than the clippings, and that benefit has stayed over 18 years in terms of the risk of rebleed when you compare clip versus coil. But it's different, and you get this argument all the time about wide neck aneurysms, and you'll have this debate about, MCs are not included, wide neck aneurysms. So there are issues, and of course there are difficulties, and there are issues about managing the branches, making sure that the aneurysm is occluded, and a significant proportion of our aneurysms are wide neck. And then there are different options. You can choose the type of option that suits in your practice, but many of these can be achieved by balloon-assisted or stent-assisted coiling. But how does it matter? Because, at the end of it, if you do a simple coiling, we know the mortality morbidity is very low. And there are a number of studies, but as you increase the risk of the procedure, when you start doing balloon-assisted coiling, you obviously improve your efficacy, but also you are increasing your complication rate. And so is flow diverters or stents, and you have to be aware of it. Showing you a case, which I think I'm going to see how much time I've got and how much time we can. My phone's anyway. So let's start with this patient. This is a chap who was homeless, presents with a subarach, as you can see. And the CTA, you can barely see the aneurysm here. You can see a bit of a nubbing of the aneurysm here. You can see that. The predominant component of the aneurysm is thrombosed. And then the angiogram shows the aneurysm, as you can see here. So you can see that you got a ACOM aneurysm, and you got a very kind of a blister-like component of the aneurysm. And that you can see it here. I went in and I double ballooned it. As you can see, you got balloons on both sides, and then I coiled the aneurysm, and that looks okay, and that looks okay, and that's okay for immediate. But I haven't got the pictures here, but this aneurysm looks pretty okay, but there was a significant thrombus component here, and this aneurysm recurred. And in fact, to be honest, the reason I used double balloon was because the only part you can see was here, but I knew there was a thrombus here. And you can see the coil ball is all going the thrombus as well as in the neck of the aneurysm. But once you got a balloon across the aneurysm, you can put coils inside the aneurysm and it's all going to be okay. But this aneurysm recurred, and I think he went for clipping because the surgeon managed to manipulate the patient for clipping. Um, so it shows that you can treat many aneurysms, but not all aneurysms. Look at these MC aneurysms. They're all not the same. You can see this one is very different than this one, or this is an acute ruptured aneurysm with a blister. So how can you have the same treatment for all aneurysms? So it's very important that you can focus and choose the type of treatment that you want, which is good for that aneurysm. And it's important because if you just do wide neck aneurysms, and I showed you earlier, if you do wide neck aneurysm, you will get a good result in terms of mortality, morbidity. But your occlusion rates obviously are much lower than what you see in other, stent assisted coiling or any other treatment. So we know that pure coiling is good, but I don't think it always necessarily gives you that efficacy. And of course, you might have arguments from some people, well, we just go and I can coil the aneurysm again. Yeah, sure, if that's what you want to do. But, we know that you will end up doing in a significant proportion of patients, you will repeat coil. Let's look at this aneurysm. You have well, is stent good? Well, I'll show you this lady, a 71-year-old lady. She was treated for this aneurysm outside. That recurred, obviously. Got treated again, as you can see, recurred again. And I think that this time she came to me. As you can see, the MR, there is a significant proportion of the aneurysm which has recurred. I decided to treat it with a stent assisted coiling. So you can see what I've done is I put a balloon on this side, I put a balloon on this side, coil the aneurysm, and then I T-stented it. As you can see, there is a stent here and there's a stent here. T-stenting, I thought it's a great result. Perfect. She was okay. She had a little bit of drain also put in because she's got a big aneurysm. She was doing very well. On a Friday evening, she dropped her GCS. This was like a week down the line. She got intubated. She had a seizure. I drove from Manchester. And I came in. The CT didn't really show much. The angio was done in the night. It doesn't show anything. But you know what? There's a perforator probably which has got blocked here, and you can see I didn't know what was going on till I looked at the notes, and I realized that she was not on antiplatelets post procedure. Everybody forgot. Nobody prescribed her. She was on the ward. She was seen by me multiple times too. Never realized that she was never given any antiplatelets. And you can see she had a perforator infarct and she sadly died. And this highlights that these things happen. People forget to take antiplatelets, or we make a mistake, and then you can get into trouble. So if you look at different papers, but the overall figure, then I use stents and I tell patients the morbidity and mortality is around 10%. So 10% is the number that I gave patients of complication related to a stent. Depends on the location. But the mortality, overall mortality is low, but the morbidity is around 10. And always everybody is Rene Chapeau. And I think we need to understand that we are all not superheroes. So we need to have something that's easy, something where you think it's an intrasacral device, but then there are limitations, and we need to understand the limitation. And this is why I'm not even showing you the technology till I know and you understand that we got to know what is available, what's the mortality, morbidity, and how we can continue to improve these devices. These devices are not made for narrow aneurysm, which are coilable. So we should try not to do them because we can coil them and they do well coiling. These are designed for wide neck aneurysms, complex aneurysms, intention where we would have landed up using stents, and we want to prevent using or not use stents so that we can avoid the problem that we can see with stents. Obviously, the advantage is no stents, no antiplatelets, but the disadvantage is that it's still not the best technology and there are limitations to it. And that's why we have to kind of know those limitations when we use them. And there are tons of them, and the tons are coming. And today I'm going to not rest. I'm not going to talk about eclipse. I'm not going to talk about RTs. Some of them have gone, PCONUS and all. So we're going to restrict ourselves to web, Neqstent, and contour, depending on the time that is. Aubrey, just tell me when I need to stop, okay? I haven't got my phone with me. So what is the feature that we want in an intrasaccular device? The feature is that we want a device, or we want a technology that treats an aneurysm which is safe. We want something that will show good occlusion. It's easy, so all of us can use it. And pretty much, if the device can have all these characteristics. Now, everybody today talks about webs. I got involved with webs somewhere around 2012, I think, 2012 years. So this is where I came in. This is where. So 2012 double layer. And look at how it has evolved from a double layer, which I used to use, to a 17 system. Things have changed, not necessarily in the right way. And there are different ways, and this is all Paul's slide where he talks about using web, with stand and coils. I do like this idea. I do like this idea sometimes. I don't like this idea unless I am in trouble, or I have no other choice, but I have to use it. But technically, web was designed as its own, and you should be able to get an occlusion with web alone. And if you're using stand, you might well use coils and it'll do the job. Here is a standard left MC aneurysm that you can see here. Technically very straightforward. You put a web there, as you can see, the web is here. You got a good device. The aneurysm looks like a web. You can treat it like a web. As you can see here, the aneurysm is treated. Here is a Paul's case again, where he has a big aneurysm here, and you can see that he has cocked the device here, and then you can coil distally. Yes, of course, you can use the web more elegantly, more innovative way, and you can do the same job without trying to put a stent around the aneurysm. Okay, you can just avoid that, and you can get a good result, and that's a good result there. What is important now, and it's very important, and all of us know there are multiple studies that have shown the mortality and morbidity associated with web is significantly low. So people who will argue about stents and webs and stents and stents and stents, they cannot give us the mortality morbidity as low as what we can see with web. We also know that the occlusion rates, although in this study they seem to have a complete occlusion of 50 and adequate occlusion of 80, and that has stayed in different papers, we know it's not 100%. We absolutely know it's not 100%. So now you will have debates about adequate occlusions, and we know that these trials necessarily do not reflect real life practice, but the ballpark somewhere figure of recurrence rate is around 15 to 20%. So that's what you are looking at. So remember, out of 100 patients that you will treat, you may get 20 patients that may recur, but then you got 80 patients that are treated with web who don't need antiplatelets. So you are only restricting to those 20 patients. And again, you don't need to treat all of them. So sometimes, which we know from the data from ISAC, that the rebleed rate in a lot of these aneurysms is very low with coiling. We know that web works in acute also. Again, the mortality morbidity is very low. So, look at a case here. This is a standard silverfish hematoma. You got a nice MCA aneurysm. You don't need to go and do magic there. You drop a web, as you can see, takes a few minutes, treat it with web, occluded, hematoma didn't need to come out. And here, and this was a 2-year follow-up, and you can see the aneurysm is occluded. And we know that web in smaller aneurysm, when you extend the benefit of web from where you would have used in wide neck, when you do use in small of these aneurysms, we use it for trying to get the procedure done quickly, safely, and you get a good result in the long term. If you have somebody like this who's an alcoholic with a partially thrombosed aneurysm, and then you put a web in there, you can see there's a double layered web put in there. It's never going to work. You can see I have treated it, looks okay. Came with a subdural. I didn't want to give him antiplatelet because he was, again, not going to take antiplatelets. And it's recurred. As you can see, it's recurred. And look where the web is. The web is here. So the web has gone into the thrombus, and I've retreated him because, again, I didn't want to give him antiplatelets. And there you can see, and he wasn't going to take antiplatelets. I knew he wasn't going to take. So there's no point. It's a wide neck aneurysm. You either can coil it, which I did. I used a web, and I got a good result. But you know what? Again, it's never going to work. 3 months down the line, he presented with subarach and he died. I tried to coil him, and again, this time I didn't try to put any webs. I coiled him, but it was not going to work, and he died. So we know that the web in certain aneurysms will not work. You need a stent. If you look at this one, we know the problem with web. If this web here, you can see there is a bit of an endo leak. I didn't realize that. You can see that the patient did have a small thromboembolic post-web. 4 years follow-up, you can see there is recurrence of the. So you do get late recurrence in the web too. You get compaction with web. What is the problem? The problem was that there was always endo leak, and this endo leak wasn't going to stop, and you're never going to get this because it was small. The largest web you can use is 11. So the largest aneurysm you can treat is probably about 9. If you use a web, it's going to recur. I think if you problem with a newer web, here you have an aneurysm which is small. You have then a 17 web was put by somebody here. As you can see, the web is not going to work here. It's small, it's undersized, it get detached. As soon as it get detached, it's moved, and now we got a problem here. You can see the web has moved. This is a problem. And previously we had a nice, big, sturdy device. Now we got a softer device. So we have to manipulate the device in a different way to take the tension out, to make sure it doesn't move, make sure you size because it's too soft and it will just flip inside. And there you go, and then you'll end up with a cleaner. So is web a perfect device? Well, it is not, but nothing is perfect. It's safe, it's good, it's easy to deploy, you don't need antiplatelets. But it's not that easy to size, which is still a problem. And again, it's still not the same results that you see with stents. So we need to see something better. And what do I use for? You'll see in time, you'll make your own opinion. But I know when not to web, when I don't have the right size, don't web partially thrombosed aneurysms, and you always use stents with that. And when the shape is not well, when the rupture point is at the neck and I'm not going to be able to cover it, and cost. If it's a coilable aneurysm and you're going to get a good result and it's going to get occluded, then you coil. If it's wide neck, it's different when you think it's going to recur. And obviously, avoid, I don't use stents as a routine with webs. So we need something that's got combined properties of web and flow diverters, which is as safe as web or coiling, but slightly better. And anybody, and obviously, no, try and avoid that. Try avoid that. Try avoid that if you can. Certainly not cardiologists and neurologists. That was a joke. Um, so what does contour do? Okay, this contour it's an alternative. Again, we want all these things in a contour. It's a double braided device. Many of you would have seen this. The aim of the contour is to control the neck. That's what you want. And I want everybody to think that the contour needs to go quite often here like this. This picture is incorrect. Okay, it has to come no. Why? Because you want to create a bifurcation. You want to create a vector there. So you want to come down as close as you can. And this is the problem. This is the fundamental thing that you need to remember when you do contours, that you want something that sits like this. Okay. You sit like this, it will go up. You sit like that, so you need to come down in the neck, control the neck. Okay, it's a double braided device. You can't re-enter it. It's connected here. It's electrically detachable, and I'm sure everybody of you has seen it. In the earliest cases, I see a termination aneurysm. Put a contour here, as you can see, and the contour has 6-month follow-up, 12-month follow-up, 2-year follow-up, 4-year follow-up. Gone. Para-ophthalmic aneurysm, as you can see, the extension, you can continue to change. You can see now the contour has been dropped here, and you can see the contour has got now, I come out always. I always come out here. I give some antiplatelets also. I always will come outside the aneurysm. And then you got long-term follow-up. These are early studies that you see, because obviously you want data. You can see the complete occlusion rates that we have in Leeds series, which has been recently submitted. We are looking at complete occlusion rates around 60%. And an adequate occlusion rate, we are looking around 89%. Obviously, we don't have follow-up in all the patients, but that's not bad. It's not 100%, but we are looking at around 85 to 90% occlusion rate. The serious study again looks at the same thing. Again, complete occlusion around 48%, adequate occlusion around 90%. This is around 1 year follow-up. And then one of the interesting thing, and obviously the mortality morbidity was very low. Not surprising. All intrasaccular devices, I think they all are pretty good in terms of the mortality morbidity. What's important is the if you look at the this video is not working, but basically you are looking at something which is interesting, how contour is different from the the um, the web, is that you get this occlusion rate that kind of improves over time, which is what you call as a progressive healing. As you can see here, this is a case for right MC aneurysm that you can see. I dropped a contour here as you in the right MCA. She had another aneurysm on the left side, which I put a web because the contour at the time was not available. You can see at 6 months, the web looks okay, but I was a bit disappointed that I got some endo leak here probably. Wasn't sure. I brought her back and I was going to do the angio, and I did the angio, realized she developed brachiocephalic stenosis. So my aim was to come down here, put a stent here, and then go from here and treat it, to go up and then treat the right MCA. But as you can see, when I brought her across to put a stent here, so she's got a stent here, and but when I went up, the aneurysm was occluded at 12 months. So it's very important to realize that there is the device behaves like a flow diverter, and then you got a follow-up, and here is a 2 year follow-up that you can see the aneurysm has continued to remain occluded. How do I choose between web and contour? Well, if you got a flat base, you probably want to use a web. If it's a neck is a bit rounded, you want to use a contour. Here is a flat base basilar termination aneurysm, as you can see, and you can see that it's a web, and you can see this is an ACOM. Again, it's a flat base, so you can see you can put a web here, and you can see the web has been placed here, and that looks completely occluded at 2 years. If you got an angulation like this, then it looks like probably a contour. Here is a web recurrence. You can see the aneurysm is coming like this. You can just go at the back of it and kick up his ass, and then you can put a contour there. There you can go. Here you can see if there are branches coming off here. As you can see, there are branches here. You can go down and just drop a contour in the aneurysm. So you get a nice reflection, and you get a nice device sitting at the middle, but not always. Here you can see this is a pica aneurysm, as you can see, but it's an acute subarachnoid, and I don't use contours at the moment in acute unless they are quite big. But here you can see this one. I can easily put a web there. Why would I need a contour? I just put a web and it works, and it works. If you got branches coming off the neck, you can construct, but sometimes you may get into trouble. Here you can see this is a neck aneurysm. You're going to try and put a contour here. No, it's not going to work. As you can see, you've got some problem with some coils and all. The best is to just put a stent across, or you just go and put a web. As you can see, this one, the web was more appropriate. You can see it's much more flat, and you can get a web sitting here, which is much better than putting a contour. As you can see, this is Thomas Liebig's case. And sometimes you get more freedom if you got contour, because the device is a little bit softer in terms of the web, which is we need a via. You can have SC aneurysm, basilar termination aneurysm. You can see that the device of web versus contour, you have much more freedom Here you can see the contour was placed and it worked pretty okay. The important thing is when you have this angle, you can see the length of the device in your microcatheter is half in contour compared to web. So it's a lot easier to push when you got an angle and you want to try and get a device. So you can think between the two and you can choose between the two. Here you got a small shallow aneurysm. I'm not going to show whether I want to put a VR there and a web which has got a pointing that the distal tip, which can be difficult, and you got to be careful. You can just drop a contour there, and that will work. If you have a big recurrence, and you want to use a stent, yeah, you can use a stent, but you can get a contour that will allow you to get a good neck coverage here, as you can see, and then you can just have a contour sitting here, and you can coil the aneurysm. Then you don't need to put a stent across there. So that's a kind of big benefit. You have a pericarosal artery. Again, some of these cases are from different places. Here you can see the contour has been used. You got a ophthalmic aneurysm, you can use a contour. You got a big aneurysm, this is difficult. We got a 14 millimeter device, the biggest. I think it's still a problem and it still could recur. But if it's an acute, you can use a contour to get a bridging, and then you can coil it, and then you can use, and you don't need to use a stent. But if it's undersized, very likely this will come back in 6 months, 1 year, and you can treat it. So, I like both these women. But you don't have to choose. You can have both if you like. Let's say shut up. It's there are people who will criticize, and I'll show you why these criticisms come. Look at this aneurysm. This is an SC aneurysm. It's nasty. There is a vessel here, as you can see, the P1 on this side. There is a right P1. There is an SCA coming here, and then so you see it's a complex aneurysm. Is this a good one? You can see again, there's one vessel coming here, one coming here, one coming here. This is tricky, and you can see that coming here. So how do you treat this? Again, I think for me, this is a stent case. Well, you can use contour. Well, somebody has tried to put a contour. And then you see, this is a post-procedure, a shed. It's never going to work. And you can see here, the aneurysm has recurred in 6 months or something, 6 months, 1 year. I got to see this, decided to retreat this. Now this time you can see my aim was to put a flow diverter here and find a way of protecting it. You can treat in different ways, but the very important thing is to protect the SCA. So what I did was I had a catheter for a flow diverter. I put a device here, and then and aim was to put some coils, but I didn't even need to put coils because the contour worked and the stent worked. And I think that you can see the flow diverter here. You can see the contour is here. The SCA was coming here, and that device just stayed. I didn't need to put any coil. There was some manipulation needed, but eventually you can see that's the result I've got. I think, the treatment of choice, it is obviously the flow diverter. You could have put some coils there, and that would have done the job too. When you don't size properly, like here, this lady has recurred because you can see I missed the posterior endoleak here. The device was sitting here like that, and I have not got a good result. So you have to be careful. When you don't size it, you're not going to get it. This is the right MC aneurysm, which I was proctoring. 11 millimeter contour was not doing very good. Maybe it should have been webbed. Well, when for a 9 millimeter device, what's going to happen when you put a 9 millimeter device in an aneurysm which needs 11 millimeter? It's going to go in, and obviously then you double sandwich it, and then now you have to put an 11 millimeter device, and that was okay. So, be careful. There are people who don't like any intrasaccular devices, and but in summary, both of them are safe. Both of them, contour offers a slightly better occlusion rates, but you need a long-term data. But you need to also learn to deploy that properly. Otherwise, you're not going to have this. You're going to have the same occlusion rates or recurrence rate unless you bring the device to the neck, to the bottom of the artery. Aubrey, how much time have I got?
That's great, Tufail. If you've got any more to give, that's great, Tufail. If not, if you finish, that's fine too. So it's up to you.
I'll just quickly. Well, I can show Neqstent some other time. Okay, so Neqstent is a completely different topic. So anytime later, we can always talk about Neqstent. All right. But I'm
Yeah,
hoping that you get the flavor of what contour and web and where they both stand. I think anybody who uses intrasaccular device needs to remember the benefits and where you can use it, but not necessarily use it in every other aneurysm. And I think that's where the problem starts. Um, thank you. Any questions? I can happy to take.
right. Are there any questions, please, for Tufail?
Great.
Brilliant. So, Tufail, what would you say the learning curve is for utilising a contour compared to? Do you think there's a learning curve that you need to take in terms of number of times you need to do it, or anything like that from your side of things?
For contour, I think if you are already a consultant trained in intervention in endovascular, it's a lot less. It's a lot less. The problem is that I think it's about making sure that you get that adequate training to put it in. I use a new device today, I still get somebody who has used it before, at least once, and translate that experience from that operator to you. And I think we need as a team to be very careful that we get that message right. Industry wants to sell the device to us. Our job is to make sure we learn to put that properly. Otherwise, you're going to get in trouble. Okay.
Okay, great.
Thank you.
Anybody else have any other questions? Okay. Well, with that, thank you very much.
Thank you, guys. Thank you.
For talking everything, and I'll close the session.
Thank you.
I'll
Thank you.
recording. Thanks very much, everybody.
Bye.
Thank you.
Bye.